graphic designing client who just finished a major advertising campaign, working very long hours at the computer, complaining of neck pain with a tired, numb feeling into the right arm and palm of hand, causing weakness and difficulty at work. Excuse me. I apologize for that. Before going into the full clinical assessment process, I decided to ask a few questions to the client. Firstly, I asked how much more specifically they've been working, and for the last 2 months, they've been working on average 60-hour work weeks where they've been working 6 10-hour days to try and get this project done. They have not been exercising regularly, and yeah. So when they first walked in, I noticed that they were guarding their neck on the right side, specifically the scalenes, with their left hand. Their head was slightly turned to the left side, shortening the muscles on the right side, and they and their right hand was relaxed, in a limp state, not really doing too much. Next, I did the examination of movement, and I chose the C-spine for this. So first, an active range of motion. I noticed that flexion and rotation to the left and lateral flexion to the left all were limited and reproduced the neurological symptoms. For passive range of motion, all the other active range of motions came back normal. For passive range of motion, at the end range, there were symptoms reproduced again in flexion, left-sided lateral flexion, and rotation to the left in the C-spine. I was supposed to skip. Here we go. Perfect. And for resisted range of motion, everything only reproduced symptoms at the end range, and there was some weakness in those movements. For a peripheral joint scan, I chose to do a peripheral joint scan instead of a rule out because of the neurological symptoms indicated in the beginning with the hand, and also there's no known mechanism of injury. So for the peripheral joint scan, I started with the TMJ. So first I did depression of the mandible, which came back negative, and then I did lateral excursion, which did reproduce symptoms to the when I added overpressure in the left direction. And then for the arm, I found that in the GH joint, flexion with overpressure was normal, but abduction with overpressure was able to reproduce the symptoms again. In the elbow joint, I did pronation and flexion with overpressure, and the wrist I did extension and ulnar deviation, which for the wrist and the elbow both came back negative. And then I also in the fingers did opposition and flexion, and those also came back negative. So for the functional assessment, I had the patient I love this picture. I had the patient pretend to type for a bit at a chair with a raised table. And yeah, I noticed that as they settled into their working posture, they had exaggerated kyphosis in the T-spine and the anterior head tilt and those forward rounded shoulders. This was pretty much all I had to do, or all I did to them. I had them do because they were fatigued and in pain, and I didn't want them to run through a bunch of... I just needed to see them sitting, because that's what they've been doing for so long. So next, for special tests, I decided to do compression and distraction because those are my favorite tests, favorite neurological tests. So I started with neurological testing because, again, like I said, that was indicated before. We don't know the mechanism of injury. So I started with compression because this can either rule in or rule out a nerve root lesion, and this was ruled out. This came back negative. There was no symptoms recreated. So then I did a distraction for them just because that's, you do one, then you do the other. So since I still suspected it was neurological, but knew it wasn't a nerve root lesion, I had the idea that it might have been a peripheral nerve, peripheral nerve lesion. So I did upper limb tension test 1 first, which was positive, and then I did upper limb tension test 2, which also came back positive. So that was good. I had 1 thing rule out and 2 things rule in. So yeah. So I knew it was neurological and most likely median nerve due to ULTT1 and 2 being positive. So next for neuro, since I only had 1 option here to really confirm what was going on, I decided to use the peripheral cutaneous sensory map and do a sensory scan using the peripheral nerve map. And I found that when I did this, like they explained before with their numbness in the palm of the hand, they did have median nerve numbness. They did not have too much numbness up the arm, and it was really more in the palm and the wrist, and this just gave the illusion that the numbness was actually going up into their forearm, but they really just didn't know when the sensation stopped. Next, I decided to do myotomes and deep tendon reflexes just because that's what we do in this semester, and those both came back negative. The myotomes all had normal, sensations that didn't really line up with any myotome. Oh no, sorry, myotomes. The strengths were all normal, and normal 5 out of 5 strength, and for the deep tendon reflexes, a rating of 2 came back for the brachioradialis, the biceps, and the triceps, all negative. Next, I moved on to joint play, and for this, since they did have pain in their neck still, and in their shoulder still, I decided to go a little bit lighter, but I still chose, because they had restriction in abduction and extension, I decided to do, for the seeing the restriction abduction, to do an inferior glide of the GH joint, and to help with extension, to assess the level of restriction in extension, I decided to do an anterior glide, which I don't remember doing, but yeah, and that is that. And then next, for palpation, I palpated really the area that was the chief joint that was the complaint, so the schneck, the shoulder, or I mean the neck, mainly the C-spine, and I noticed that the anterior scalenes, especially on the right side, were very, very taut and tense, most on the right side, but bilaterally, and there was also pec major and minor tenderness and fascial restrictions. They also had a general weak posterior upper back involving the upper traps, um, supraspinatus, and all those muscles. They did have neuropathy / pain in the palm and wrist, which after all the testing they feel like could possibly be coming from some form of thoracic outlet syndrome. So after all this information, I decided to make the clinical hypothesis that the main issue with this client currently was a median peripheral nerve lesion.